from the mechanical point of view, this screw is working 50%. If you agree, it's getting just one cortex, there's nothing here inside, and not getting the second one. Whenever I do the same here, I'm perforating the first cortex that is really thinner than the diaphyseal one, and I get all the metaphyseal bone here, all the cancellous bone in addition to the first cortex up to the second cortex there. So maybe this is not working 50% from a mechanical point of view, it's holding in the bone maybe 70% or 80% or is 90% long as it would if I would perforate the second cortex, but much more powerful than that one. So we could say we're getting one cortex here, so this is maybe a monocortical screw because it's not getting the second cortex, but it's not the same as it was here. So I do want bicortical screws every time in my diaphyseal bone, if possible, if I need it. I don't really care much if I don't get this thin cortex in the metaphyseal bone, especially when I have 3 of these bones. So whenever I use a locking plate, and I know from the anatomy, from the X-ray, from experience, that my drill bit is going to aim into the joint, I perforate the first cortex, I leave my power drill really soft, I'm not going to push, until I feel that it's touching the second cortex. At that point, I retrieve, I take the measurement, and I put a screw that is 2 millimeters shorter, not longer. I don't want to perforate the joint. Make sense? So from a mechanical point of view, we can use locking screws as monocortical screws here, but working 80–90% from a mechanical point of view. But at the level of the diaphysis, I would go bicortically until I don't need it. And when I don't need it is when I don't want my implant too rigid. So in that case, maybe if I have 3 screws in the diaphysis, maybe I can use 2 screws bicortically and 1 of the 3 out of the 3 monocortically. But it's a decision coming from experience and experience with that kind of system you are using. So whenever we do a fracture repair in a cat, as this was anatomically, with no external fixator, no mobility, this is how the cat is going to go 1 week after surgery, so already using the limb, still limping obviously, and after 2 weeks, and 2 weeks after surgery. So easier to manage than with an external fixator, for sure. This was the healing in 6 weeks. I didn't touch the other piece of bone that was there. I didn't use that as bone graft because I was able to put together all the pieces anatomically. And so that healed with secondary intention, not with primary intention, secondary intention. And the fracture healed uneventfully in 6 weeks with an open and minimally touching the bone fragment with a closed with an open reduction in a young cat. So was really a healing machine also this one. This is the cat under sedation, checking range of motion, and with anatomical reconstruction, range of motion was normal in 6 weeks because the cat was able to walk, to use the limb, to flex, to extend, to wash his face, and to do all the things the cats do during healing. The only thing I avoid was the jumping and obviously the running. Okay, I want to stay in, I want to follow the agenda, so we are gonna go to little dogs. Have you got questions on these cases, on cats, on internal, external fixation, decision making?
Вопрос такой. Всем кошкам, которым ставим на костные пластины, через 15 месяцев назначаем контрольный рентгеновский снимок, чтобы определиться, нет ли защиты от стресса. И если видим уменьшение плотности костной ткани, соответственно, убираем имплант. Правильно понял?
Yes. Yes. Yeah, this is a really good question. We haven't dealt with the stress protection phenomenon in the past. We have found the first stress protection phenomenon with the using of the locking plates, because they last almost forever. They still work over time in months and years. So the stress protection phenomenon usually comes really early. So if you don't see it in the very first month, it's not going to happen. It's not going to occur. So if you check the dog or the cat at 6 to 8 weeks, and you see good healing, you recheck after 1 or 2 months. If you don't see stress protection phenomenon, it's unlikely that will happen in the future. The case I showed you was one of the first case I did, and at that time I didn't know that. So I know these things because I checked a lot of them over time. But now I do X-ray check after 2 months, and then maybe after another 2 months, and if I see that is everything okay, I can just ask for a recheck at 1 year, but just to be more than sure, because I want to be more than sure. But just in 4 months, you see if you have an issue. Thank you for this question. So let's move to little dogs. Treatment of fractures of distal, radial fractures in dogs. It is not. So have you ever got a fracture of the distal radius and ulna in a pincher or a chihuahua? They are challenging, aren't they? They are challenging. Why they are challenging, in your opinion? So the problem are the size of the dog. In the past, we didn't have the right size implant for that tiny dogs. Now we have something to deal with, something to use with the small dogs and tiny dogs, fortunately. There are publications. Randy Boudreau demonstrated a few years ago that vascularization of the distal radius and ulna in tiny dogs is weaker, even in proportion, than in large and giant dogs. And also activity restriction is an issue. They usually live at home. They don't want to stay in a cage. They're going to bark all the day long. So they get mad. They open the cage. They leave the dog jumping from the couch. And the couch in a tiny dog, jumping from a couch for a tiny dog, is like jumping from the first floor for us as a proportion. Make sense? Because they are really tiny. So, whenever you see a dog with a fracture of a distal radius and ulna, how would you manage this fracture? We can make the choice to get in or out, as usual. How would you treat this distal radius and ulna fracture? They are usually in young dogs. What's the problem in young dogs? Is the hardness of the bone. Some dogs, some adult dogs, they have their bones are hard as marble or as teak wood, the wood we use to make floors. In tiny young dogs, the hardness of the bone is as the cork we use in the bottles, right? So where implants don't hold the same. So there's an additional issue. So the size, the way we can confine the dog, the hardness of the bone that is not holding the screws or the external fixators. And then also the size of the external fixator. For example, if you put an external fixator in a tiny dog where the diameter of the distal radius is 4 millimeter, we know that not to weaken too much the bone, we don't want to exceed 25%, 30% maximum of the diameter of the bone with the pin. But in a 4 millimeter thick bone, how much is going to be 25%? It's 1 millimeter thick pin. And you can put your clamp 1 centimeter or 1.5 centimeter from the bone outside of the skin, and 1 millimeter pin, 1 millimeter thick pin is gonna bend. It is not strong enough for that kind of dog. So we need at least a biplanar configuration or a ring, as Elizarov taught us. So there are many, many considerations when we do the decision making in distal radial fractures. So the choice is in or out. How many of you go with the external fixator as in their practice when you get a distal radial fractures? External. Okay, a few. How many use internal fixator? Yeah, even more, the double. And there are also way to manage this in some cases with a cast. because they are young, they heal in a few weeks, and so if they are really young, you can manage with a cast. How long is gonna function a cast, is gonna hold a cast in your practice, in your experience, before you get issues with the skin? In my practice, 2 to 3 weeks. After 2 to 3 weeks, I'm starting having issues with the skin. So in the case I foresee a healing in 2 to 3 weeks, maybe I'm going to choose a cast in that dog. But to get healing in 3 weeks must be really young. This dog must be a 4-month-old dog, 4.5-month-old dog. That depending on the size also of the dog. This is not a tiny dog, but that was just an example. It's not a deformity issue, it's a fracture of the distal radius there, and you see that wasn't displaced, at least the ulna was little displaced, also the radius was little displaced, but that dog was so young that I put him on a cast, and I got the healing in a few weeks. This is different. This is a Chihuahua that he got the fracture following from owner's arms. 13 months, 1.8 kilo. 1.8 kilo is a dog that stays in my hand. This big. And maybe from here to there is 4 millimeter thick, this bone. So we need to make a decision. We've got informations, so we now are doing our interpretation, and hopefully we get the solution. So what's the difference from an internal fixator, as the fixing system is, and an external fixator? In your opinion? In my opinion, it's just where they are. They function the same way. This locking mechanism I will introduce to you is a mechanism using a conical coupling, is as the same as the bone clamp. It locks the screw in the plate as the external fixator does. The only difference is that the external fixator is out of the skin, outside of the skin, and the fixing plate is inside the skin. So these two systems are comparable as strength, because this is really close and this is far from the bone. So the longer is the lever arm, the thicker must be the external fixator because of the lever arm. On the opposite, the shorter is the lever arm, the thinner could be the external fixator. So, can I ask you a favor? No, stay here. Can you raise your hand this way? Thank you. I really need to push hard to have his hand lower here, but I don't have an issue doing that here. And so that is the opposite. So if I go close to the bone, I'm stronger. And the way the metals or the things in general resist to flexion, so the strength, flexural strength of things are managed by these formulas. And if you consider this as being a plate, this letter W means the flexural strength, so the capability of this bar to resist to flexion. is given by this formula. And if you look at the formula, you have at the numerator, you have a power to 2. At the denominator, you have nothing as the power. And this is the shape of a plate, so it's rectangular in section. And this is the shape of our pin, so it's rounded in section. Even with the pin, we've got a power to 3 at the numerator, and we have no power at the denominator. What does this mean? This means that the resistance to flexion is exponential. So we need just to make the pin a little bit thicker to make the pin much, much stronger. So if we double the size of the pin, we are not going to double the strength. We are making this strength a few times higher, greater. As an example, those are just pins, and this W that we were looking at is in a 2 millimeter pin in diameter is 1.57. And if we go from 2 to 3, we are not getting just 50% more strength, but we are getting 4 times, 3 times and something more strength, not half. If we go from 2 to 4, look, we go from 1.57 to 25. So I would say 12, 13 times just having the pin, the double in thickness. So if we put this on a graph, we see that the thicker is the pin, the higher is the strength on flexure, the flexural strength, in this kind of proportion. So when we put a 1.0 millimeter pin in a tiny dog, we get we see here 1.0 tiny pin is 0.10. And if we put a 1.5 millimeter is 0.5, is 5 times thicker. Just having the pin 50% thicker than before. But many times to get this, we need to have a 1.5 millimeter pin in a bone that is not big enough for that kind of pin. So the stress protection phenomenon we see is really likely to happen in tiny dogs because of this reason. Because we go from one pin to another pin that for us is just a little bit thicker, but for the dog is 5 times more powerful in resisting to flexure. So is 5 times more rigid. So the most challenging thing in these dogs is to choose the proper plate and screw and the proper external fixator configuration. More than the vascularization in my experience and practice. So we can use locking systems as an external fixator or non-locking systems. Non-locking system provides stability through friction. So the screws pull the bone on the plate, and the friction between the bone and the plate makes the stability. With the locking system, it's like the external fixator, there's no friction there. So they preserve more the vascularization. There are many ways to get locking plates, but essentially on the market there are 2 systems. One is based on the conical coupling, And another one, the other one is based on the tread. And there are many based on the tread. And actually the Alps is based on the tread and on a larger conical coupling. And now also the Canyon TPLO plates are based on the conical coupling as the fixing, but with no bushing. So what now? We get this little Chihuahua. You see how little it was. This is my hand. So it was inside my hand with this distal fracture of radius and ulna. And we know that the bone is thicker on the frontal plane rather than on the medial-lateral plane. But when we do external fixator, we usually go from medial to lateral, distally, or from craniomedial to caudal lateral. So when you use an external fixator, you usually go from that side where the bone is thinner. Instead, when we use the plate, we usually go on the cranial plate, cranial side, so where the bone is wider. So from that point of view, the plating is favorable against the external fixator. So we can use here a thicker screw in case we need it. So if this dog has a 4 millimeter thick bone diameter here, and we can use just a 1.0 millimeter pin, maybe here is 5.5 millimeter in diameter, not 4, and we can use a 1.5 millimeter screw, not to exceed 25% of bone diameter or 30% maximum of bone diameter. So using an external fixator, maybe we can use here 1.0, 1.2 millimeter pins. Using an internal fixator, maybe we can use here a 1.5 or a 1.9 millimeter screw. This is an anatomical consideration. And distally, this is at this level. If you see how the bone is at this level, you can realize that getting here from cortex to cortex is not that easy, even with an external fixator. Much easier getting from here to there. And here we can talk about having a monocortical or a bicortical screw. We have two cortices. We are at this level. But look at what happens if I make a scan here at the level of the scar of the physis. In the transverse, I have a filled bone of cancellous bone. A very thin cortex. Look at how thick is the cortex in the diaphysis. And in the metaphysis is half or 1/3. But I have the bone that is filled by subchondral bone, that is a good bone for holding the screws. And so we can speak here of bicortical or sub-bicortical when we get up to here, not to penetrate eventually the joint. So these considerations are really important to me. Now we have the X-ray of that very dog. That was a 9-month-old, 1.8 kilo. We would consider a 9-month-old in a Chihuahua an adult dog, because their physis they close earlier, because it's a tiny dog. And this is the small fragment here maybe if this 4 millimeter, we have 8 millimeter here or 10 millimeter, not big room to put things. Is a 9-month-old dog, very active, not possible to be managed with a cast because he's not going to heal in 2 weeks or 3 weeks. He's not young enough. So maybe I have the measurement. Yeah, I have the measurement. So this is 2.5 millimeters, so even thinner than 4. So 2.5 millimeter here and 3.7 something here. So less than 4 here and 2.5 here. How much is 0.5, 25% of 2.5 millimeters? Less than 0.8, 0.7 millimeter. Would you use a 0.7 millimeter with an external fixator? You won't. You can, if you use a ring, you can use a 0.6 millimeter little wire in diameter in tension through the ring. So in this case, one ring with 2 crossed 0.6 or 0.7 millimeter pins would work. And then proximally another ring here and maybe half of a ring there. Or other options. In the case we would go using a plate, I would choose for sure the cranial aspect where the bone is thicker in diameter. And this is 3.7, maybe 3.7 millimeter in diameter there. So what's the size of the screw? What's 30% maximum of 3.7? 12? 1.2 millimeter screw.